Good morning. Uh, Respected ML Swankar sir, Sir Jay sir, VK Kapoor sir, Himan Malhotra sir, distinguished faculty, colleagues and residents. It's my privilege to introduce you to give a brief about our Department of Neonatology before starting the case. So we have started the DM Neonatology program in the year 2021 and we were the first in the state to start this program. 2 students we enroll each year and our first batch has recently passed. So this is our inaugural batch and the external examiners were very happy about their performances. These are the faculty members. In our team we have Dr. Madhu Mathur ma'am, Professor and HOD, myself, Dr. Arjun Verma, and our newest member, Dr. Satyen Hemrajani. Now I give a brief overview about the NICU. We have 23 bedded NICU and we take care of preterm babies from 25 weeks onwards, and we have dedicated neonatal transport services also. And our yearly admissions have been rising steadily. So whenever we talk about NICU, we think about ventilators, monitors, infection control measures, and about parental anxieties also. So we are proud to have 5 high-frequency ventilators, which are state-of-the-art with ventilator graphics. We have 4 non-invasive ventilators, and very few centers they have non-invasive ventilators. We have dedicated neonatal non-invasive ventilators, and we believe in non-invasive ventilation. So no ventilator-associated pneumonia. In monitoring, apart from clinical monitoring, we have invasive blood pressure monitoring, and also we do functional echocardiography. So we do point-of-care ultrasound, and we thank the management to give us in-house echocardiography machine to do point-of-care ultrasound. We do point-of-care of ultrasound not only of the heart, but lungs, brain, and abdomen also. And we use this in placing central lines, in checking endotracheal tube position, and in doing procedures like lumbar puncture. So we have parental nutrition facilities, but we believe in starting the full feeds in preterms from day 1. So no lines, no cannula, and no sepsis. And in this way, we are able to restrict sepsis to a large extent in our NICU. And then we believe in the family-centered care. So the mothers, to boost their lactation, to allay their anxieties, the mothers, they are allowed, they have unrestricted access to the NICU. We also allow fathers in the NICU. The mothers, they do kangaroo mother care, the skin-to-skin contact with their preterm babies. And we strongly believe in mother's own milk. So we have the facility of the human milk bank. So in the human milk bank, it was established in the year 2016. The donated milk is pasteurized, it is sterilized, and then after the sterile culture reports, it is dispersed to the parents. So in the year 2016, when the breast milk, this human milk bank was started, we had doubts that whether who mothers will donate and whether the parents will be ready to accept other mothers' milk for their own preterm babies. But it was Sir's vision that more than 2,000 mothers have donated till now, and we have dispersed more than 25,000 units till now. We are serving other hospitals also. So it is the human milk bank is not only saving our preterms, but it's saving the preterm babies throughout the city also. And our nurses are our pillar of strength. They are just like second mothers to our tiny warriors. And to reduce drug-related errors by them, we have developed a Google Sheet-based calculator. So now in a newborn, the pharmacotherapy is very difficult if you want to prescribe any medicines, because you have to take care of the gestational age, postnatal age, the drug dilution, what the volume you have to give to the baby. So the Google Sheet, it calculates automatically the volume, what nurses they have to give. So this minimizes the drug-related errors. And same way we have calculators for parental nutrition and enteral nutrition also. So these we have 4 ongoing research projects.
Sorry, this Google Sheet is we have taken from somewhere, or we have devised it?
So we have devised.
If you have devised it, please get it copyrighted.
Okay.
Okay, get in touch with the IPR cell. And my request to all faculty colleagues, anyone has devised any protocol, any calculating sheet or anything which is new, please get it copyrighted. It goes in your name, it goes in university's name. University gets a benefit from your work. Please.
So we have four ongoing research projects, and we have published 19 peer-reviewed articles till now. And these are some highlights of the media coverages. Our human milk bank, survival of over 24-weeker twin babies. They had birth weight of around 500 grams. And then we also do cooling in the cases of birth asphyxia babies to improve their neurodevelopmental outcomes. And these are some faculty awards. We have been honored with Jaipur Medical Association, Lions Club, etc. And our faculty represents our hospital in various national conferences on neonatal ventilation, point-of-care ultrasound. We have hosted 2 national workshops also. We believe in simulation and problem-based learning. Now, if we benchmark our performance against national and global standards, our neonatal mortality is just 7.3 per 1,000 live births, which is far below the state's average of 25, national average of 18, global average of 17, and the WHO target to achieve 12 by 2030. And we take pride that we have comparable survival to apex institutes like AIIMS New Delhi. But this all would not have been possible without the support from our board of management, from ML Swanka sir, whose vision always guides us, Sajdev sir, VK Kapoor sir, and all other departments like Department of Pediatric Cardiology, Pediatric Surgery, Nephrology, and other specialties. Thank you so much. So now I invite Dr. Shaleen for
Saurabh, before starting, you mentioned that you start full feed for the preterm babies.
Yes.
So what is the effect on intestine? Because I have seen the gangrene if you start in preterm babies. So you
yes, sir. This is a very good question, sir. Because earlier people used to believe that necrotizing enterocolitis is caused if we start the feeds early. But in India, the majority of the preterms, they are mostly more than 30 weeks onwards. And in those babies, the necrotizing enterocolitis is mostly due to sepsis. If we insert cannula, if we give unnecessary antibiotics, if we insert central lines, that increases sepsis more. So earlier we were also skeptical in starting the full feeds in 30 weeks. But we have, from last 10 years, we are doing this, and we didn't get any feeding intolerance or necrotizing enterocolitis. Thank you.
Thank you, sir. Good morning, everyone. I am Dr. Shaleen Parmar, first year DM Neonatology resident. I will be presenting case history for today's CCR. Before going to current illness, let me brief about maternal and antenatal background of this case, which is very vital. A mother is 27 years old. Notably, parents were in consanguineous marriage. Mother is gravida 3, para 2, abortion 1, and live 0. Her second pregnancy was complicated by a baby with refractory neonatal seizures, which unfortunately died due to underlying illness on day of life 2 in outside hospital. No diagnosis was established in that baby. In personal history, there was no history of any narcotic or alcohol abuse, no family history of epilepsy, and no significant history of repeated miscarriage in family. Coming to current pregnancy, the mother presented to us at 37 weeks of gestation. It was unbooked case without any antenatal records of fetal genetic testing. Outside antenatal scan was normal and no workup done for previous neonatal death. It was high-risk pregnancy for which emergency cesarean was taken with primary indication being fetal distress. Fortunately, baby cried immediately after birth with Apgar score of 7 at 1 minute and 8 at 5 minutes. However, it was noted that baby had severe fetal growth restriction with birth weight of 1800 grams and baby developed respiratory distress at birth. Baby was immediately shifted to NICU with working diagnosis of fetal growth restriction and respiratory distress. On admission to NICU, baby was having respiratory distress since birth, baby was having tachypnea, baby was having subcostal and intercostal retractions. Baby was immediately taken on non-invasive ventilator. Bedside lung ultrasound done, which was suggestive of transient tachypnea of newborn. Bedside chest X-ray done suggested mild free fluid in right middle zone. Enteral nutrition was established by nasogastric tube. After 24 hours, baby was in hemodynamically stable state. On examination, there was no dysmorphic features. At 24 hours of life, we have our provisional diagnosis: term baby with fetal distress, growth restriction, transient tachypnea of newborn, and previous neonatal death secondary to refractory neonatal seizure. On day of life 2.
Can you go back a slide? You have to explain this slowly because very large part of your audience doesn't understand much about neonatology.
Yes, sir.
So do you call it, when do you call it growth restriction, when do you call it growth retardation, and what is transient tachypnea of newborn?
Sir.
Can you just elaborate for?
So at term gestation, 37 weeks, the ideal newborn weight should be more than 2500 grams. Birth weight below that is considered as a low birth weight, is considered fetal growth restriction. And sir, we did bedside lung ultrasound done, which was suggestive of transient tachypnea of newborn. So transient tachypnea of newborn is respiratory distress seen in term babies due to delayed clearance of fluid from lung. The lung fluid is basically seen in the posterior and the lower lobes of lungs. It is well appreciated in lung ultrasound, and in X-ray in right middle zone there is a horizontal fissure suggestive of transient tachypnea of newborn. On day of life 2, clinical picture changed dramatically. As seen in video, baby developed myoclonic seizures. Baby was intubated and kept on conventional ventilator. Central venous access was secured for better fluid management and drug administration. Baby was kept nil by mouth. On the onset of seizure, baby was given first anti-epileptic drug, phenobarbital. At the onset of the seizure, baby was euglycemic with RBS of 110 mg per deciliter. It is important to note that on day 2 neonatal seizure, there was no history of any birth asphyxia. Baby was euglycemic, and there was no hemodynamic instability. There was no signs of sepsis and asphyxia.
Before starting phenobarbital, did you do EEG of this patient? Electroencephalogram to differentiate whether it is an actual seizure or some jitteriness or something else?
Sir, we first gave the phenobarbital. After that, we order for the EEG, 24-hour EEG, sir. Baby remained unresponsive to first loading dose of phenobarbital. After 30 minutes, if there was no response to phenobarbital, it prompted us to give second loading dose of phenobarbital. After giving first line anti-epileptic drug, there was no response seen in this baby. After 60 minutes, a first loading dose of levetiracetam, that is second line anti-epileptic drug given. Still no response after 90 minutes. Second loading dose of levetiracetam given. Here, after giving first and second line anti-epileptic drug, no seizure was still persisting and no clinical changes seen. It fits in the criteria of refractory neonatal seizure. As per the international consensus proposed by Epilepsia, failure of adequate trials of two tolerated and appropriately chosen and used anti-epileptic drug is defined as refractory neonatal seizures. After giving two anti-epileptic drugs, 4 hours, seizure was still persisting. We started our third line anti-epileptic drug. Baby was started on midazolam infusion at a dose of 6 mic per kg per minute. In next 12 hours, as there was no significant difference, no clinical improvement in seizure, the midazolam was gradually up titrated till maxing out the dose of 18 mic per kg per minute. We did the initial workup for the neonatal seizures. Initial lab parameters, including CBC, were within normal limits. Serum calcium, electrolyte and magnesium were within normal limits. CRP was normal and blood culture was sterile. CSF study done which suggested normal parameters. CSF glycine and serum ammonia were within normal limits. However, ABG done during refractory seizure suggested metabolic acidosis and lactic acidemia. Here, initial workup for seizure, including CSF glycine and serum ammonia, were within normal limits. But after giving 3 anti-epileptic drugs, baby was still having recurrent seizures. We consider underlying neurometabolic or genetic disease, genetic pathology. For this, we took the consultation from Pediatric Neurology, and further evaluation including EEG was done. Now I would like to call upon stage Dr. Riya, second year MD resident. She will brief us about EEG including further workup. Thank you.
Morning everyone. I am Dr. Riya, second year MD resident of Pediatrics department. I am going to discuss about EEG and further workup for this case under guidance of Dr. Ajay Goenka, Assistant Professor of Pediatric Neurology. So this case presents neonatal seizures of the patient on day of life 2. There was history of fetal distress, but there was no history of perinatal asphyxia. Seizures were unresponsive to first, second and even third line of anti-epileptic drugs. Also there was a positive family history, a previous neonatal death which was secondary to neonatal seizures. So this is a baseline EEG. As we can see, previously we used to do amplitude based EEG, but now we do standard based EEG, which is the gold standard investigation to monitor the brain activity. This baseline EEG is a standard baseline EEG in which we can see the red line represents the brain activity from the right side of the brain and the blue line represents the brain activity of the left side of the brain. This EEG was 10 seconds of brain activity. So as we can see, there is a burst suppression pattern along with high amplitude and multifocal spikes which suggest a severe cerebral dysfunction. So what we decided to do next was to go for a sequential drug trial with IV pyridoxine with the dose of 100 mg and to monitor the brain activity. So these were the results. As you can see, even after administration of pyridoxine, there was burst suppression pattern which could suggest uncontrolled seizures which patient was having continuously. So EEG was suggestive of multiple electrographic seizures with characteristic burst of spike and wave discharges. This burst suppression pattern was indicative of severe encephalopathy and non-convulsive status epilepticus with no response to pyridoxine. So my question is for pediatric residents, what differentials can you think for refractory neonatal seizures with no response to pyridoxine? The differentials which we can think for refractory seizures which are resistant to pyridoxine can be inborn error of metabolism, especially non-ketotic hyperglycemia. Second one is pyridoxamine 5-phosphate oxidase deficiency. Its deficiency can lead to neurotransmitter issues which can trigger the refractory seizures, polinic acid deficiency and mitochondrial disorders. So what we decided to do next was to give a sequential drug trial for pyridoxal phosphate. So this was the baseline EEG which we had seen earlier. There was no change even after giving pyridoxine. So we decided to go for oral pyridoxine phosphate with the dose of 60 mg per kg per day in 4 divided doses over the next 3 days. And the brain activity was monitored and the results were as this. As you can see, after giving pyridoxal phosphate for the next 3 days, the EEG showed significant normalization of the background activity with only few multifocal spikes with no clinical seizures. This was the baby on continuous video EEG monitoring after starting pyridoxal phosphate. So a possible diagnosis of pyridoxal phosphate responsive seizure was made. Patient was continued on IV midazolam and was advised to taper it down gradually and was continued on levetiracetam on maintenance dose and phenobarbital was stopped. Patient was started on levomethylfolate and pyridoxal 5-phosphate and continuous video EEG monitoring was done. To further confirm the diagnosis, clinical exome sequencing, MRI brain, tandem mass spectrometry, gas chromatography mass spectrometry was advised. Now I'd like to call upon stage Dr. Ankush Khanna, second year DM resident of Neonatology, to discuss the case further.
Good morning everyone. I'm Dr. Ankush Khanna, second year resident in DM Neonatology. I'll discuss the approach to refractory seizures in neonates. So to begin with, we should know the seizure semiology, the age of onset of seizures, the treatment resistance and other features. And then we go for whether it is age-dependent differential diagnosis, and we also consider the genetic biochemical factors for the same. First of all, we go for the tier 1 investigations. And in this, we do the initial workup, including the plasma glucose, lactate, ammonia, and blood gases, blood and urine amino acids, organic acids, and plasma acyl carnitine profiles are also done. So in our baby, the RBS was normal, lactate, ammonia were normal. Blood gas just after the seizure had mild metabolic acidosis. However, TMS and GCMS were found to be normal. So we went ahead with the imaging studies. We went ahead with MRI of head, proton, MR spectroscopy, continuous video EEG monitoring, and ophthalmological assessment. So these were the findings in MRI of our baby. We found that there was diffusion restriction in the cortex, and there were multiple hemorrhages also in the deep white matter and the periventricular matter. So these changes are generally consistent with hypoxic ischemic encephalopathy or metabolic encephalopathy. But since there was no history of asphyxia, the diagnosis was more towards the metabolic encephalopathy. The MR spectroscopy showed lactate peak inversion at 1.3 ppm, as we can see. Again, this points to the probable diagnosis of metabolic encephalopathy. So this is the machine we use in our unit to do the continuous video EEG monitoring, and the ophthalmological assessment for the baby was found to be normal. So then, as Riya told us, we went ahead with the sequential therapeutic trial of pyridoxine, folinic acid, and pyridoxal phosphate. There was baseline EEG, which showed the burst suppression pattern. It showed no response to the pyridoxine, and then we went ahead with pyridoxal 5-phosphate, and we saw that the baby improved clinically as well as in electroencephalography was normal. EEG became normal within the next 3 days. Important point I'd like to emphasize over here is that had the baby shown no response, we should have continued the vitamins for 2 weeks prior to stopping it if response was not elicited. So this is very important for us, because if we would have not made the early diagnosis, it would have actually injured the brain of the baby permanently. So our early and systematic diagnostic approach was very important in not only saving the life of the baby, but also giving the baby a perfectly normal neurological development. So we finally sent the tier 3 investigations as a whole exome sequencing, and it came out to be positive for a pathogenic mutation in PNPO gene. This is especially significant because just around 100 neonates all over the world have been diagnosed with this pathogenic mutations. And we call it pathogenic because those neonates were also having encephalopathy and epilepsy. So once this report was there, it was a moment of gratification and sheer validation for our department, because our diagnosis ultimately was confirmed with whole exome sequencing. So I'd like to discuss what is unique about our neonatal seizures, how are they different from adult seizures and pediatric age group seizures. So as we can see in the video, the most common seizures in the neonates are the subtle seizures. Around 50% of the seizures are subtle seizures. We have some seizures in the leg of the baby, but we'll just turn around the head of the baby so as we can see the ocular buccal movement to see subtle seizures more efficiently. So we can see subtle seizures over here, and we do not get generalized tonic-clonic seizures in neonates as opposed to adults. Now, this is generally because of the fact that synaptogenesis is not complete in the neonates at birth. It continues in the pediatric age group. So that is why we don't get typical generalized tonic-clonic seizures in the neonates. Secondly, we also get electroclinical uncoupling in the neonates, which means that even if the seizures have stopped clinically, we may still get the seizures on EEG. This is again because of the fact that the myelination is not complete. The chloride channels are still not mature. That is why we get this electroclinical uncoupling. And lastly, there is limited therapeutic consistency of anti-epileptics, including phenobarbital and midazolam in our neonates. Thank you. Now I'd like to invite Dr. Shiva on stage to brief us about the progress of the case.
For the clinical course, we had continued to do EEG, and the EEG had only shown small multifocal spikes, which may have been only potentially epileptogenic, but there were no clinical seizures that we could see, as well as the sensorium having improved over the next 7 days of life. And we had slowly tapered IV anti-epileptic, and we had switched over to oral anti-epileptics. As far as hemodynamic status is concerned, the baby had remained hemodynamically stable for the duration of the hospital stay. and we were able to extrude the baby on day of life 4 while continuing video EEG, and we were able to wean the baby off the room air from invasive from NIPPV on day of life 7, and the blood gases that we had done in the duration were all normal. And as far as nutrition is concerned, the nutritional requirements of the baby were being taken care of via parental nutrition, and we were able to start the baby on enteral feeds by day of life, and we were able to progress the baby to full feeding, that is by day of life 7, and we were able to initiate skin to skin contact and initiate kangaroo mother care at day of life 7. The routine supplements that we start in any newborn were started on day of life 7, that is the vitamin D3 and multivitamins.
What is the policy in our department for the kangaroo mother care routinely, Dr. Saurabh? Are we prescribing? Are we doing it regularly for all? So can you explain to the audience what is kangaroo mother care? It's important for the
kangaroo mother care is like a kangaroo keeps a newborn baby in his womb. Actually, in the kangaroo, the baby is known as Joey, and the baby is preterm baby. So the baby is kept in the kangaroo womb till the baby matures. So in the same way, the mother does skin to skin care. And it is not just skin to skin care, it increases the mother confidence, it boosts lactation, and it is like a wholesome therapy for the development of a newborn brain.
Continuing forward, we had switched over to oral antiepileptics, and we had tapered the medication to oral levetiracetam, as well as we had started the other targeted therapy for the baby, that is vitamin B6, pyridoxine, as well as its active form pyridoxal phosphate (PLP). For feeding, we had initiated something called oromotor stimulation. These are stimulatory exercises that we do on the oral cavity, the soft palate and the lips. This helps us to transition the baby from from nasogastric feeding to direct breastfeeds in the other time taken to transition is quicker if we start the baby on oromotor stimulation. And we were able to transition the baby to spoon feeding, and by day of life 12 we have switched over to direct breastfeeding. This is our ultimate goal in any preterm baby. We aim to initiate direct breastfeeds as soon as possible, and by day of life 13 we were able so in essence our job was done, and now it falls on the mother to take care of the baby. So we had repeated the EEG again, and there were still a few spikes, but they were not significant, and the baby had not shown any convulsions. And by day of life 13, the baby had regained birth weight, and we were able to de-escalate our care from level 3 and to level 2 and level 1, that is the care that any normal well baby is given, in view of the baby having acceptable weight gain. And by day of life 18, we were able to discharge the baby on the other routine supplements as well as the other targeted supplements, that is pyridoxine and its active form, sir. So before discharge, since this baby was a case of refractory seizures, it behooved us to do a screening tool. So this is the Hammersmith neonatal neurological examination. So you can see that in the video the baby is moving spontaneously all the 4 limbs, as well as there being no subtle seizures in the video. And the baby is also, the tone appears to be normal, as well as when you are able to lift, there is no, the tone in the legs is normal. So this over here you can see that the our screening tools, the short form. So the findings, most of the findings of the baby on examination were found to have fallen in the shaded part. If the findings are in the shaded part, that means that the assessment is normal, but the one finding, that is arm traction, that was there in the warning signs. So this warranted that we should repeat the examination on follow-up. So now I invite Dr. Sehaj Randhawa to speak about the other publication details of the same case.
Good morning, everyone. I am Dr. Sehaj, a second year DM resident, and I will go through the review of literature and the publication. So as we know that we have discussed earlier that the paradoxamine 5-phosphatase oxidase deficiency is rare, but it is a treatable condition. So as of 2022, only 90 babies have been identified with having a PNPO deficiency. So, yes, all over world, sir. Reported cases are confirmed by the whole genome sequence. So basically they are of two types. One is classical that contributes around 90%, and other is late onset that contributes around 10%. If we talk about the classical, the onset is within a neonatal period, that is within 28 days of the life, and they are characterized by the intrauterine seizures, and the baby and they do have the fetal distress before the delivery. And some of them may have the encephalopathy, and they may land up into the status epilepticus. Whereas those who have the late onset, around 10%, they have the onset after the 28 days of the life, and they do characterized by the epileptic spasm and the cryptogenic seizures. So if we talk about the pathophysiology, the molecular defect in the PNPO deficiency, actually the basic defect lies in the chromosome 7. There is a defect in the PNPO gene, and due to which there is a deficiency of the paradoxamine 5-phosphatase oxidase, because of which deficiency the paradoxin is not able to convert into the active form of the vitamin B6, that is the paradoxin 5-phosphatase, and due to the which there is the glutamate dehydrogenase become non-functional, eventually leading to the decreased synthesis of GABA that correspond to the neurotransmitter imbalance, as the excitation part increases and the inhibition part decreases, so eventually leading up to the neonatal seizures. And if we talk about the interesting clinical features that we can encounter during the PNPO deficiency, one is that the seizure can be of any type, right from the myoclonic to the clonic or the tonic. It depends baby to baby, and we can have an episode of roving eyes, along with there is a head movement. It might correlate with the EEG pattern or not, and around 60% of the babies do have a developmental impairment, like it can affect their speech, cognition and the behavior, and some of them may have a muscular hypotonia or the dystonia. And if we talk about the systemic finding, they present as a respiratory distress and vomiting and abdominal distension. So basically the whole point is that we can't differentiate the baby just on the basis of systemic finding and other findings whether the baby is having a particular gene defect or not. In the neonatology, every baby behaves in a particular fashion only. So this was the baby that the baby that had a PNPO deficiency. As we can see that it is very difficult for the pediatrician or neonatologist to identify a myoclonic seizures, as they can be very rapid and they can have a very burst appearance, like they just behave like a clonic seizure. It's just that they are more quicker and they neonate appears more jerky. And it's very important to that we identify as myoclonic seizure, because they have the very worst prognosis among all the seizures that we can encounter in NSU. And they, the most part is affected is the flexor muscle, and as we can see in the video, the movements are very erratic, fragmentary and generalized. They do we do confuse with them the jitteriness and other type of seizures, but it's important to differentiate, as the jitteriness is a very common phenomena, like they have a very good prognosis as opposed to the myoclonic seizures. So if we come about the how can the simple vitamin, the active form of vitamin B6 can save a life in a newborn in NSU, this case highlights the same fact. Like if there is a fetal rhythmic movement, it can alert the mother early. It is important that we keep a differential diagnosis of intrauterine seizures, not only because of the baby having a fetal rhythmic movement is normal. We have to look into other aspects also. And if we think that there is any history of a refractory seizure and the baby has expired after 1 or 2 days, and if we do get the positive history like that, then we have to start the prenatal PLP therapy early in the early in the fetal period, as it can save the future pregnancies and the baby can have a as good as the normal prognosis as in other babies.
And your Department of Fetal Medicine and Ultrasound,
Yes.
high level ultrasound, level 4 ultrasound,
Yes.
during the pregnancy has to be very good.
Yes.
All right, to start all these things.
So this was the whole point of the case report was that the baby responded on the pyridoxine 5-phosphatase and did not respond on the pyridoxine. So it is very important that we will be very precise with the vitamin that we are delivering to the baby. So it's important that we diagnose the early, as we highlighted the fact that the baby may have a normal outcome if we intervene early. So in the if we come to the prognosis, like if there is absence of specific treatment with vitamin B6, the baby may have early neonatal death, and if we can save the baby, we have to. And other thing is that preterm babies, they are affected more as compared to the term baby. The developmental delay in the preterm babies have been reported around 84%, is quite significantly more as compared to the term babies. And if we start the treatment within 4 weeks, it positively correlates with the better outcome. So bedside lesson that we have learned during this whole scenario. One was that the antenatal history of the fetal tachycardia and the distress before the delivery, it might be possible intrauterine seizures. We should not label it as only a fetal distress or other things. We should keep all the options open as a neonatologist. And the other thing is that if we are giving the conventional therapy of the conventional drugs like phenobarbital and lavapril, if the baby is not responding to that, then we have to think of other causes, like there might be underlying metabolic or genetic cause to that. And we should not wait for the report to come. We should start the trial of giving a folic acid and the pyridoxine as early as possible, because as we have highlighted that if we give the therapy within 4 weeks of the neonatal seizures, the prognosis becomes significantly improved as compared to others. And about 60% are become resistant to the pyridoxine, and they do require the treatment with the pyridoxine 5-phosphatase. So like as this baby was having a refractory seizure, so it becomes our job as a neonatologist to follow up with these babies. So we have to make sure that while we are doing the surveillance, we have to look for whether the baby is having a proper seizure control or not, and we have to look for the proper assessment of the growth and the neurological finding. Is there any significant finding? And other thing we have to look after the liver function test, as the pyridoxine 5-phosphatase have a hepatotoxicity, and we have to closely monitor the SGOT, SGPT, and along with that we have to throughout the counseling we have to be very sympathetic towards the family, as they can be having a difficult time around. So in a nutshell, if I say that we have to look for the growth, and we have to look for whether there is any breakthrough seizures or EEG was normal or not, and we have to look for any neurological examination, as Dr. Shiva has already highlighted in the examination part. So this was the publication that we have done in the International Journal of Scientific Research. So with the help of Madhu ma'am, Saurabh sir and Arjun sir. Arjun sir was the corresponding author for this publication, and we have published this publication. It is PubMed journal in the Google Scholar, as already 90 cases were identified throughout the world, so it was easy to us to publish this case. So I will pass this mic to Dr. Arjun sir for the rest of the slides.
So good morning everyone. I am Dr. Arjun, Associate Professor in Department of Neonatology. Now you have all gone through the case and you know that this case was really challenging. Why? Because let's take on the take home messages. The first and the foremost thing is that this highlights the importance of the past history very much, because a neonatal death once before and an abortion before, all two things should alarm us in terms of definitely being a genetic or a metabolic origin, because the exactly similar clinical features started developing in the third neonate. Okay, that's very important. Never just see the baby and start treatment. Always take a deep history in antenatal history, dig into it. Where is the problem? That's my message would be to my MD and DM residents. Second important thing, had this been a case in a periphery, it would have been treated lifelong as a hypoxic ischemic encephalopathy, and maybe the baby might have died like the similar baby in the previous, like the previous neonatal death, and they would have continued as HIE, and they would never have thought as metabolic origin. So that's why very important to consider when you fail in your anti-epileptics, switch on to your vitamins and vitamin B6 and try whether the EEG responses. Sometimes the people do a rookie mistake where they give vitamin B6 and they think that the EEG will be normal there and then. Well, this happens with pyridoxine but doesn't happen with pyridoxal 5-phosphate. It takes around 3 days for the EEG to get absolutely normal. That is why we need to have patience and see whether the clinical response as well as the EEG response is there. Then only then we can confirm it. Definitely at this point of time, we were sure that we are dealing with something which is related to either pyridoxine or pyridoxal 5-phosphate. We didn't have the diagnosis because the whole exome sequencing generally comes after a very long time and the baby gets discharged by that time. So in our discharge summary, what we had kept it as pyridoxine 5-phosphate deficiency, probably a genetic origin. Now, very important is to approach the case in a systemic fashion. Now, we didn't think in an erratic decision. What we did was the basic normal things. First, we started phenobarb, then levera, then midazolam, and then we went ahead and get the EEG done. And thanks to the basic infrastructure, the excellent state of art, the pharmacy support to provide us with the pyridoxamine 5-phosphate in an advanced time within 48 hours of requesting, and the clinical acumen with that, believing in following the exact approach of managing any disease. And it is not just with the neonatology, it is also in pediatrics and adults. I would emphasize that always go ahead in an approach in a systematic way so that you will always reach to a diagnosis. If you go in a systemic way, stick to your basics, you will definitely reach the final destination of your path, that is your diagnosis. So this was the baby. We were very happy to see this baby, and there was a very much emotional aspect in this case when in our neonatal follow-up clinic, when we saw the parents' happy face, because they have already lost one child as an abortion. The second child was died because of neonatal seizure, and this was the third child, after which they had lost all the hopes. And had this baby had been diagnosed before, when the second baby was delivered, through either a DNA sampling when the baby had died, or if the baby would have been treated well, we would have known that this baby is suffering from vitamin sensitive seizures. And in the third pregnancy, if the mother was alerted that if you get fetal rhythmic movements, then you should see the gynecology and obstetrics department, and you can consider pyridoxal 5-phosphate therapy also, and you can get in initial period of obstetrics, you can get the amniocentesis, and there and then the diagnosis is. So it's very, very important that if you get abortions, recurrent miscarriages, and if there is a history where there is previous neonatal death, always work up during the obstetric period. Second important thing is support of pediatric neurology. It would not have been possible without the expert Dr. Ajay Goenka from United States, who has come us and blessed Mahatma Gandhi with such a good pediatric neurology team, where we were able to diagnose within 48 hours that this is vitamin sensitive seizure. The state of art of NICU, the continuous EEG monitoring, the equipments we have, the EEG technician was so good and was so humble in following us and cooperating us with daily EEGs when we took the baby down, as well as we continued the baby with continuous EEG monitoring in ICU. All these things collectively helped us in cracking the case within, I would say, less than a week. And because of these efforts, we were able to ensure an intact neurological survival. I would like to emphasize that if these seizures would have ongoing and the pyridoxine therapy would not have started, this baby either would have died again, or this baby would have had a severe developmental disorder and intellectual deficit, and would have developed a severe dystonia or hypotonia, or in that case baby may have died also. And till date the parents thank us for treating the baby in a particular systematic way and reaching to the final diagnosis, which none of the tertiary periphery cares could have done. And the icing on the cake was exome sequencing. We discharged the baby as saying that this is vitamin sensitive seizures, and finally we left the case. And when we saw the exome sequencing, it was very fortunate and a happy moment for the department. Unfortunately, it was not fortunate for the patient, because this disease has 60% cases of developmental delay, but still 40% there is a hope if you start the treatment in a positive way and very early. in the life if you start and stop the seizures. And because of which this was an icing in the case where we got the diagnosis there and then, and we hit the nail, and finally we found out that this was pyridoxamine 5-phosphate oxidase deficiency. So with this, I thank the entire team of my DM residents, MD residents, Dr. Saurabh sir, Dr. Satyen sir, and the entire team.
How old is the baby now?
So the baby was born in September 2024, and currently baby is at present around 7 months. We have followed up for 2 follow-ups at 1 month and 4 months, where we found that the development was as per the age. There was some element of hypotonia that generally seen with this disease, but it was not affecting the routine developmental milestones of the baby. So with this, I end the today's CCR with some few more happy stories of an extreme preterm saved by 27 weeks. We have done in our department that we always take a photo of the parents when they get discharged. Then we had extreme preterm 26 weeks. Then we had a challenging case of congenital diaphragmatic hernia, and thanks to Siddharth sir for an excellent case management, and we were able to save a case of CDH. Then we have a very preterm 30-week with Madhu ma'am, and then extreme preterm 28 weeks. These are the various happy stories of our NICU, which relentlessly keep us on our toes to save these extreme preterms. Thank you.